Hello, my name's Alpana Mair and I'm going to talk to you today about addressing the challenge of polypharmacy. I'm Head of Prescribing and Therapeutics at Scottish Government and I lead an EU project called iSympathy, stimulating innovation in the management of polypharmacy and adherence through the years. What is polypharmacy? Polypharmacy simply means taking more than one medicine. And I'm going to talk to you about where polypharmacy is appropriate, where it benefits an individual, and this can easily be the case if we think about somebody presenting with cardiovascular disease, where taking 10 or more medicines may be completely appropriate, whereas for another individual, taking 3 medicines that are causing side effects may be harmful, and that's what we term inappropriate polypharmacy. So if we think about population and ageing, if we look at the data of people in 2015 and countries where 30% or more are over the age of 60, we can see that from the chart on the left that there are not many countries that have that proportion of people. However, once we look forward to 2050, we can see that many more countries have a population where people are aged over 60 or more, and that figure you can see by the dark red area of countries that have 30% or more that are over the age of 60. Why is this relevant? It's relevant because as people get older, they then present with more than one long-term condition. So more people have multiple morbidity than a single disease. And you could see that from this data that as people get older, they are more likely to have multiple morbidities. With increasing multiple morbidities, people are also likely to therefore take increasing medicines. We need to also think about the importance of functional status versus age so that we take a person-centred approach. This is to ensure that we think about people's well-being and their preferences rather than just making a judgment on the disease that we're treating. For example, think about the lady that's very active in this picture on the left, and then think about this gentleman that's slumped on this sofa. Now, if both of these people presented with cardiovascular disease, we would treat them exactly the same because a standard guidance isn't going to differentiate between the two. However, if we think about the intensity of management with medication that the lady on the left might have, some of these may make her lightheaded and dizzy and make her undertaking her activity very difficult. Whereas with our gentleman who slumped on the sofa, we'd need to manage him very actively with treatment, but also lifestyle judges. So it's really important that we think about the person, we think about the functional age, and not just the actual chronological age of an individual. We also need to think about the fact that as people move through life, they inevitably get prescribed lots of different medicines. And if we look at the chart on the left pictorially, we can see that people are given different types of medication at different stages. And then as they get older, very likely with multiple morbidities, they get prescribed lots of medication. We do know that as people get older with potential renal and liver impairment, the body's ability to metabolize medicines and excrete them becomes impaired, and therefore people become more prone to some of the harmful side effects of the medication. We also know that frailty can have an impact, and frailty can sometimes mean that people also take more medication. However, it's these same people that are more likely then to be prone from the harmful side effects of these medications. And we can see here that if we look at the Scottish data, this chart pictorially represents the people that are taking multiple medicines. And you can see from this that some people over the age of 85 are taking 15 plus medicines. Now that's not 15 tablets, That's 15 different types of medicines. So it could mean that they've got 15 tablets, where for some they're having to take 2 of the same tablets. So this is a huge burden on an individual of having to take multiple medicines. So where we want to have a look at is, where does this become a problem when an individual is not gaining the benefit from a medication, where the medications are doing more harm than good. So we'd want to address inappropriate polypharmacy. So is polypill the answer? I would say not, because with that, we're still putting all the medicines into one. What we want to make sure is whatever goes into a polypill will be the medicines that are going to benefit the individual. It is possible already to have 3D printing of multiple polypills, but we need to make sure that that polypill has the right combination for an individual. Is it pharmacogenetics that we need to think about? Maybe as people get older, because that way we can make sure that people are only on the medicines that are going to benefit them. So polypharmacy has become a public health challenge. It's estimated that up to 11% of all hospital admissions are caused because of harm due to medication. If we extrapolate that data across Europe, 8.6 admissions every year in Europe happen because of medication-related harm. We know that half of these are preventable, with 70% of these occurring in patients over the age of 65 or more who are taking 5 or more medicines. So from the charts that I showed you previously, you can see that it's not a huge number that people need to take before they experience harm. These should be looked at and reviewed, and we need to think about whether a medication is appropriate or not, both at initiation of treatment but also at review. The World Bank and WHO estimated that 4% of total avoidable costs could be addressed by addressing inappropriate polypharmacy, with 0.3% of the global health budget being expended on this harmful product. So $18 billion could be saved if we addressed inappropriate polypharmacy. So we sought to look at some of this work that was happening across Europe through an EU project called Sympathy. We did this by studying 8 countries across the EU initially, by doing case studies and looking at the programs that were in place. We then looked at surveys across the whole of the EU 28 to gain lessons on what would be effective in implementing programs across Europe to address inappropriate polypharmacy. One example where a polypharmacy program has been implemented nationally is the Scotland program, where a change management approach has been used to embed a program and to scale it up. And this starts off by creating an urgency, which is about addressing the public health challenge and preventing hospital admissions, to making sure that we enable pharmacists to work with physicians as prescribers, and to embed that with funding so that every primary care physician has access to a pharmacist to work with them, and that we embed that change right across the health and care system. And through that, what we've managed to do is that we've shown that the program itself is economically viable, and the cost of the program is offset by the savings in the drug expenditure, but also by the savings in the admissions to hospital and the prevention of harm to an individual. And one of the other tools that's recommended for countries to benchmark and see where they are if they want to establish a program is to look at PESTLE and SWOT, and to look at these factors so that countries know what areas that they need to address before implementing such a program. As part of Sympathy, we also undertook a literature review and evaluated the guidance that was available across Europe. 5 countries had polypharmacy guidances, and these were evaluated and assessed using the agreed criteria. Only 3 scored the top marks against the agreed criteria. One was in the Netherlands, one was in Germany, and one was in Scotland. And this is the realistic prescribing guidance that puts the patient at the centre of the decision making around whether a medication is suitable or not for them. So this starts off by finding out what's important to the individual and making sure that we have the right medicine for the individual, that it's for the right indication, and that it's evidence-based. We make sure that we remove any unnecessary medicines or medicines where a patient is not going to gain the benefit. Where medicines are prescribed, we make sure that they are prescribed and they are addressing the issues that matter to the patient. We make sure that the patient is allowed and encouraged to report any possible side effects that they may have, so we can address the harm before it causes any hospital admissions. We need to make sure that the medicines are cost effective for the individual and the state, but also then make sure that we agree and share a plan that the patient or the carer is happy to adopt in day-to-day life. As I said, we've shown that through this programme that it's an economically viable model, and there is an economic tool that's available that was developed through the Sympathy programme that EU countries can access. And the Sympathy programme, through a further Delphi and mapping of the vision, found that participants across the EU 28 estimated that it would take till 2030 for Europe to have a programme that would address inappropriate polypharmacy, so that all harm was prevented from medicines, but people gained the maximum benefit from the medicines that they were taking. And this was launched by our Cabinet Secretary that you can see in the middle, but also the lady on the right is from WHO, who endorsed the programme and came to speak at our final event. And this also led to the Global Health Challenge, the WHO Third Patient Safety Challenge, Medication Without Harm, where polypharmacy was highlighted as a key area to address unnecessary harm and improve medication safety. So the key recommendations from the Sympathy programme were divided into three main areas: quality, economic and political recommendations. So the first recommendation was, as you implement a programme, ensure that you've got a multidisciplinary team with a systems-wide approach, and you thinking about innovation and including pharmacists as part of the wider healthcare team, as well as the patient, working in collaboration with them. Making sure that the culture in the organisation prioritises safety and quality, where people can come together and discuss prescribing and address it, even if they have been prescribed by a different healthcare professional. Making sure that as healthcare professionals, patients are involved in the shared decision making, and one of the aspects is that we've developed these tools, patient shared decision aid tools, where patients are given information so that they can take an active role in the medication reviews and about whether or not they want to take treatment or not, and using the 7-step process. Making sure that we have data so that countries can benchmark themselves, but so that they can see where they've made improvement, and an app is available to allow countries to do that. And through use of the data in Scotland, we've managed to make sure that we address the health inequalities. So we can see in areas of deprivation in Scotland, people who live in more deprived communities present with multimorbidities 10 to 15 years earlier, and it's these same individuals therefore that tend to take medicines, multiple medicines 10 to 15 years earlier. So we need to make sure that we prioritise our services to support these individuals, and we can see that it's important that we bias to action. So if we look at our data across Scotland, over the years we can see the reduction in inappropriate polypharmacy. If we look at the chart on the left, you can see the numbers that have declined, but also the chart on the right shows the reduction in the harmful combination of a non-steroidal anti-inflammatory drug, an ACE inhibitor and a diuretic, which is a harmful combination implicated in acute kidney injury, and you can see how that has decreased with each publication of the polypharmacy guidance. And it's important that we share these tools. So these tools are available as an app so that our junior physicians and pharmacists and nurses can all access this information while they're working in whatever healthcare setting. But we also have developed data visualization tools so that on the right you can see where a person may have problem with adherence, because we know that 50% of patients that take 4 or more medicines don't actually take them as prescribed, and this is another cause of harm. So we're developing tools to enable physicians to see very easily where a patient may be non-adherent. So the third Global Patient Safety Challenge, Medication Without Harm, addresses polypharmacy and medication safety, but what it also picks up on is making sure that we address polypharmacy at the transitions of care, and we look at the medicines that put an individual at risk, and particularly the high-risk medicines. So I want to just briefly tell you about the ongoing work with iSympathy. And iSympathy is a project where we are extending the findings from the Sympathy project and implementing it at scale by undertaking 15,000 patient reviews with patient feedback across parts of Northern Ireland, and some areas of Scotland. And what this project will allow us to do is to embed and train a further cohort of individuals in some remote and rural areas to use technology in order to deliver some of these services, but also to get feedback from patients on patient-reported outcomes. So thank you for listening, and I'm happy to take any questions that you may have.